Welcome, dear dental students. In this lecture, we will show some notes about microbiology and endodontics. As you know, oral cavity is colonized by several microbes. Some of them are uh, symbiotic, have a symbiotic relationship, and some of them are non-pathogenic. Some of them are called opportunistic pathogens. That mean they only cause disease when they have the opportunity to cause it. And some of them are pathogenic. It means it cause disease because of either the mechanism that invade cells or be harmful to normal structures such as karyogenic bacteria such as lactobacilli and streptococcus mutans. They cause pathogenicity and considered pathogenic microorganisms because it harm dental hard tissues and cause loss of dental hard tissues and trauma to soft tissue. So, these microbiota, the pathogenic microorganisms that have the ability to cause the disease, have some virulence factors. These factors that allow the microorganism to cause the disease. Uh, Examples for these factors is the having villi or fimbriae that help the microorganism to move and to attach to each other in a colony and to attach to hard tissues and to invade and form cavities inside dental hard tissues and inside teeth. Some of them cause extracellular vesicles and secrete toxins. Some of them has byproducts, dietary byproducts uh, such as lactic acid and some acids that, as you know, acids leaching calcium from dental hard tissues and cause its collapse. Some are encapsulated within capsules that protect uh, the uh, its structure against saliva and against um, any washing action. Some of them has some enzymes that are lytic to collagen, for example. Some have lipopolysaccharide and polyamines. All of these chemicals and ammonia, all of these chemicals are considered harmful to dental hard tissues and soft tissues. As you know, the vital tissues in teeth is the pulp, and the pulp will form response when it is invaded by bacteria and irritated by uh, these virulent factors. The response is the inflammation. In early stages, the inflammation is non-specific and reversible. In later stages, it becomes irreversible and characterized by vasodilation and pain, and when heart tissues will be destructed, there will be invasion to the pulp, and eventually it may cause pulpal necrosis. We as endodontists will study this mechanism of invasion of bacteria to pulpal area, and the pulp necrosis have a drastic effect to periodontal ligaments and to periapical area. As you know, when you study operative procedures, you pay concern to the pulp and the pulp vitality and pulp response. And when you do endodontic treatment, the concern is all about the periapical area and prevention of irritation to periapical area. Pulpal infection may be done from dental caries or from dentinal tubules if it is large, and permeability of dentinal tubules may transmit bacterial toxins toward the pulp. Trauma and direct pulpal exposure because of trauma or a fracture. Periodontal tissues may transmit uh, microbes and irritation from periodontal lesion through lateral canals, for example. And we have the special uh, this special mechanism which is called anacoresis. Anacoresis is the transmission of bacteria and bacterial uh, toxins and virulent factors uh, invade periapical area from the blood, and it is carried for this area and supplied from blood stream. This um, this mechanism uh, explain why there will be periapical abscess and periapical cyst full with bacteria for a traumatic tooth without any exposure and without any fracture. As you know, for a traumatized tooth, uh, for some after a duration, it will be there will be periapical inflammation. Then it will be when it is chronic, there will be abscess and there will be cyst full with bacteria and bacterial toxins. From where this bacteria are brought to the area, they think that these bacteria are transmitted through blood and the bloodstream to this traumatized area, and the trauma and the necrosis of the pulp will be a habitat to colonize these bacteria. A large number of microorganism species are uh, diagnosed and differentiated in pulpal disease and periapical disease uh, in an average of 12 microorganisms, and each colony may maybe may count 102 to 108 organisms to form the colony. So a large number of bacterial species may be found in pulpal disease and periapical disease. We have to know the main note in this paragraph is the high number of anaerobic microorganism, and the colony will be found in this area. In shallow pulpal disease, uh, you will find a large number of aerobic against non-aerobic bacteria, while when you go deep inside the pulpal canal, the percentage of non-aerobic bacteria will increase until when you reach the periapical area, will be mostly anaerobes. This table show the main uh, microorganism and main bacterial species that are found in pulpal and periapical disease. As you know, when the disease and inflammation become chronic, the defense and body defense mechanism will fight these microorganisms, and there will be inflammation. There will be a transmission of the disease toward adjacent soft tissues that is called cellulitis. The transmission of bacterial species and inflammation to adjacent soft tissues such as uh, mucosa and cutaneous area and the facial spaces and muscles. It is called cellulitis, that is characterized by severe pain, redness, erythema, okay, and other uh, signs of inflammation. When the inflammation become chronic, the bacterial uh, colonies, bacterial products exudate, and dead white blood cells will be uh, aggregated uh, in a liquid that is called abscess. And you know the chronic uh, show of abscess is the lining of this abscess by epithelial cells that is called cyst. The transmission of bacteria to facial spaces is considered a bad sequelae for periapical inflammation, and the this transmission must be resisted by all means in order to stop this transmission of infection. Any necrotic pulp and any uh, necrotic residual root is considered a focus of infection to transmit disease to soft tissues and adjacent facial spaces. This transmission is uh, determined and controlled by the location of the root to adjacent cortical plate and the position of the root in the bone, the thickness of the bony uh, shell that cover the root, and the relationship of this position to a muscle are considered the controlling points for the transmission of the abscess and disease to adjacent soft tissues. For example, an inflammation of lower molar, an inflammation or abscess in a root of lower molar. If this apex is above mylohyoid muscle, the inflammation and the abscess may be transmitted for the sublingual area, and the swelling will be shown in the sublingual area. When the tooth is long or the attachment of the muscle is high, the transmission of the disease will be in the submandibular area. If the cortical plate buckle to the inflamed root, the swelling will be shown in the buccal area. So the thickness of the bone, the position of the root, and the relation to the attachment of the muscle will control the spread of this infection. The transmission, the facial spaces in maxillary area in which disease is transmitted are the facial or the mid-face, cheek, and lateral area, and for mandibular area it will be the mental, sublingual, submandibular areas, or the buccal area and buccal vestibule. All these are the transmission areas for the diseased root. In maxillary area, it may be buccal, may be temporal, and may be submesenteric area. The most important transmission of infection is the transmission into the midface. The midface transmission of disease may result in a life-threatening condition that is called the cavernous sinus thrombosis. The mechanism of this thrombosis, when the inflammation and aggregation of exudate and increase of blood flow in the midface area and cavernous area that is located posterior to maxilla in the temporal and the sphenoid area, there will be this inflammation will cause a blockage of the artery, and this aggregation of blood may cause a thrombus that will be re inserted inside the blood vessels and cause a life threatening when it occlude some arterioles or veins inside the cerebral area. In the following paper, we will show some antibiotic that by which we fight these microorganisms. You will find the appropriate dosage and the appropriate indication of some antibiotics and interaction with adjacent drugs in the following paragraphs. The main antibiotics used are the penicillin, dosage 500 milligram every 6 hours, that means 4 times a day, amoxicillin and the dosage and every 8 hours. The combination of amoxicillin with clavulanic acid may that is called augmentin, a good antibiotic in fighting periapical infection and pulpal infection. Clarithromycin, azithromycin, all of these types of antibiotics, and the main notes are the dosage and the amount of dose and the method of dosing these antibiotics. We have an important antibiotic in periapical inflammation As we said before, periapical infections are mainly 90% anaerobic. So, metronidazole is very useful in fighting uh, periapical infections because it is characterized and active against strict anaerobes. The dosage of this metronidazole is 500 every 6 hours. Sometimes we give a combination of penicillin or erythromycin with metronidazole to fight all types of bacterial species in the periapical area. Clindamycin also is an important antibiotic. We have some regime for antibiotic for medically compromised patient. Actually, uh, American Heart Association recommends antibiotic endocarditis prophylaxis regime for root canal uh, instrumentation and surgery beyond the root apex only. So when we have retrograde endodontics, that means apicectomy, or the inflammation and infection has passed over the periapical area, so antibiotic regime should be prescribed for patients that uh, that have heart problems that require the antibiotic cover, such as prosthetic heart valve or heart surgery, and for uh, rheumatoid heart disease. The regime is known by you from oral surgery courses. In this table, you will find some details about the use of antibiotic prophylaxis for adults and children and the special dosages for using the antibiotic regime for medically compromised patient in endo treatment, deep endo and inflammation of the periapical area. In case of early pulpitis, you don't have antibiotic regime for medically compromised patients only when you have a pass of infection beyond the periapical area or you have periapical or periodontal surgery. Thank you for listening for this lecture about microbiology and endodontics. Have best regards from me, Sinan A. Shwailiya, and thank you.